Great. So, participants, any last thoughts, comments, questions, other threads that you think weren't represented in the comments you just heard? Other action items for us?
Michael Fitzmaurice, Agency for Healthcare Research and Quality. I came into this not knowing what to expect, except that I wanted some moral guidance, if you will. And yes, I realize this is not a church, but it's a cathedral of learning. And what I heard was a framework for how you look at conflict of interest and its relationships. I learned that it can cause bias, and my mind jumps to, and this is one of the areas I think that probably wasn't emphasized as much as it should have been, what's the harm to ultimately to the patient from conflict of interest and bias? I think that could have been brought out more. Is the harm to me as a patient because there's incomplete or inaccurate information in making the patient decision? Yeah. Is there harm to me because the caregiver is guided by financial incentives to do one thing rather than another? Maybe, but I think most every physician I know wants to do what's best for the patient and is not saying I'll put another $5 in my pocket if I prescribe this drug rather than that drug. So at the margin, I don't know how strong those things are. We didn't get into that. There's very little evidence to looking at conflict of interest and relationships. I liked the examples that Alan brought up and others brought up. I like the framework of what do we need to do, what kind of science do we need to develop to look at what harm can a conflicted relationship cause, and then how do we resolve it? And the best we can come up right now, I guess, is what I'm going home with, is the openness. Be open to the patient, be open to professional societies, be open to the payers, be open to the government, which represents society, and provides some guidance to that. But I'm thinking about this a lot better than I would have thought about it had I not come today. So I thank all of you on the panel and those who still aren't here for giving us a way of thinking about it, saying this is more important than that. Relationships are more important than just what you see on the paper. And then the next question is, well, what is the evidence of something that could cause bias and how could that cause harm? There's much more work that's needed to be done to get down to the patient.
Yeah, thanks for that comment. And it strikes me as you say that, the learning I just got from what you said is, I think we probably don't measure the harm to the patient because it's within a system in which we can't really measure the benefit or harm to patients. So when physicians are trying to do their best, a lot of times that isn't evidence-based because medicine hasn't had an evidence base in for a lot of it. And so it's hard to then determine what is a result of a conflict of interest, for example, versus just an unknowing. And when we get better, and maybe all the patient outcome research that we're starting to do, your agency and PCORI, then maybe we'll have better measures to start to garner the evidence that we believe we need to understand this issue better.
I think that's a really interesting point too. That it resonated for me, your comment about the measurement, and I think that could obviously be a recommendation or action item, whatever this group can do in terms of your report structure. So the measurement piece is critical, and then to your piece, Sharon, about this new payer system. On the one hand, you could say that we're resource rich and resource poor all at the same time. To Michelle's point, we spend the most and we have some of the worst outcomes. So, on the one hand, we're not so good at measuring, but we can measure the dollars, and I think we could do more with those. So I like that this workshop is taking place perhaps for the 10th or 15th time, in the last 25 years. I was talking to some participants about how we just keep having the same conversation. Maybe now is the time, as we're really going to see a change in the healthcare system, to insert this in the midst of it. I do think it's going to be important as the report gets developed that there's a distinction in the shades of gray. I said you could make this a bestseller if you just call it the new shades of gray or something. The shades of gray of conflict. So if we're talking about a doctor taking something to go do promotional tours, that's a different elephant than some of the other ones that we spoke of. Large academic centers, constructing pre-competitive relationships with companies for scientific discovery. And so a lot of my comments today were more about scientific discovery and the patient voice wanting to see progress and all of the vast amounts of unmet need that we have in terms of diseases with very few treatments or not terrific treatments. So I would definitely say that this report could and should be really married to this evolving healthcare system and the value proposition.
The other piece that I think is really important is that, yes, we're having these conversations over and over again, but to continue to not only have them, but to spread the learning that we get across different sectors, different agencies. I mean, one thing we didn't talk about today in the our discussions of the Sunshine Act and the final regulations of the Sunshine Act is that CMS, who's not represented here today, was incredibly responsive between the proposed and final rules of the Sunshine regulations. The proposed rule would have lumped in all research payments as payments in full to a single investigator or the PI. So a $500,000 research grant would show up on an aggregated database as a $500,000 payment to a principal investigator. Well, after hearing a lot of comments that said, wait, that's not how research works, the final regulation indicates that research payments and grants will be on a separate section of the database. It won't be aggregated with payments for speaking and meals and the rest, and will say where the payment actually went, the organization, institution that it actually went to, and then list the PIs as people who are involved in that research. I think we have opportunities to use changes like that to help to educate. I'm glad that, Charlie, that you're here today, and I think it was also very helpful to hear in the new context that's on the ProPublica website with the re-release or the new release of the new data, the information I believe about research and how there may be more context wasn't there or wasn't as robust before. So we're seeing these changes, and I think involving each other in these conversations, being able to move this learning and the information from group to group is very helpful and leads to less noise.
You know, I do want to say that there's a huge body of evidence, not surprisingly, that physicians are influenced by financial incentives. Physicians are human beings. We are human beings. Financial incentives influence us. Physicians who own imaging equipment get more images than physicians who don't own imaging equipment. You can look at the use of certain drugs and watch some of them change as the reimbursement incentives, one drug versus another. A lot of this is at the margin. That is, it's not 50% changes and 100% changes, but small numbers. But it is not. I don't think we should leave with the impression that we have no data. That financial incentives influence physician behavior, and bad financial incentives or whatever can influence it quite badly. So I think the profession does a pretty darn good job of self-policing, but there's stuff out there, and to the extent I think part of our responsibility in the physician community is to ask ourselves, can we set up systems where that type of incentive or influence becomes less and less prominent, and the overarching goal of let's do what's best for this patient becomes the overriding concern.
Now, Alan, I just wanted to ask you a quick question on the pediatric oncology example that you laid out, the childhood leukemia piece, because the initial part of the conversation was about alignment of incentives. So what incentives do you think got aligned that altered the ecosystem? Because so many aspects changed. You know, and now it's always held out as the shining example.
When I talk to pediatric oncologists, they tell me the following: that for reasons maybe we could find the person who did this, but for reasons that remain a mystery, what was embedded in the culture of pediatric oncology was the very best care was to put the patient on a study. And that became so powerful that it worked. There was also, and continues to be, an enormous concentration of pediatric oncology cases in academic centers. There is now beginning to be a quote private practice of pediatric oncology, but for a long time there was no such thing. It was all in academic centers. There are only 14,000 cases of pediatric cancer a year, so it's not a huge population. But they developed a culture that has not been present in adult oncology, and I think we can look to them, and the fact that they've done it and continue to do it as encouragement that in adult oncology we'll never get to where they are. We won't get them all on trial, and et cetera, but that we can do one heck of a lot better than we're doing now.
Quick question to you, actually. And I'm going to represent myself as a patient. So if I come to a physician and the physician tells me that he's receiving royalties or any sort of financial incentive from industry for who he's prescribing a medication, I say I have no problem. However, the physician follows the patient. So I think, then becomes a financial relationship. And I think, I can't remember, I think it was Sally that put it out, how it becomes misconduct. So if the physician knows that the drug is not working, but because it gets financial incentive and continue to prescribe that drug, then it becomes misconduct. So I'm just asking, is it a difference? I mean, I just don't see an issue having a physician receiving.
So, surveys that have been done of oncology patients asking, if you knew if this was the best agent for you recommended by your physician, but you knew that they also had financial interest in the product, would it make a difference? And overwhelmingly, patients say if that's the right drug, I mean, I have no problem that my doctor holds a patent or is involved in this, et cetera, et cetera. So, again, I think we need to do much more research. We assume sometimes what patients in the public think, and sometimes patients, rather expectantly, patients think differently than the public. If you're not sick, sometimes it's hard to put yourself in the shoes of someone that says, let's get some things done. I have this very, very serious disease. Anytime, in my opinion, if you say that a physician continues a therapy that's not working, just to gain another fee, that is certainly bad practice, if not malpractice, and that gets pretty well self-policed.
I don't think it's going to be financial versus not having a financial. So, kind of isolate the
Yes.
relationship that the physician has with the company. The angle is the patient is not receiving the right care.
Right. Well, yeah. No, I think you're right.
There are just so many issues you bring up with that. Firstly, I don't even know what the right care is, because you can take 6 well-meaning oncologists and they will treat the same disease in different ways. Patients today, at least in my experience with patients today, it's not like some country doctor sitting out in the middle of nowhere, and it's a nice Norman Rockwell picture of the patient and the doctor. Those doctors anyway don't have conflict of interest because they're not doing research and they're not working with companies. In today's world, everybody's on the internet. Every patient is getting multiple sources of information, every patient with an oncology problem, and they're seeing multiple doctors. And so even in revealing, again, nothing hidden, that somebody is one of the people who developed a drug and is working on the drug would probably be looked at as a positive if that's the treatment that the patient wants to get. I mean, I would rather, if I'm using Avastin, a complex drug, I'd like to go to the person who actually worked with Genentech and developed it if I'm the patient, even though they're getting $1 million a year from Genentech, because there's a reason Genentech thinks they're worth $1 million a year for their expertise on using that drug. But patients have choices, and they're not, and it's all, almost all of this is transparent. It should be all transparent, but I think that the issue is just letting it be public and letting people decide what's best for themselves. And the idea that a doctor would give a drug that is known to be ineffective, I mean, that's criminal. And the fact that they have a financial relationship would make it much more likely that they would go to jail over it. So I think that kind of aberrant behavior isn't what we should be worried about, because lots of checks and balances for that.
Thanks. And to your point, there are cases that I've been involved in, certainly, where a physician said, I'm giving you this chemotherapy. I don't think it will be effective. It's end-stage disease, and we're going to take this essentially last shot. So I think you're right that those extreme cases are ferreted out, and we're back in a sense to the shoe bomber. Any last comments or questions, and then I'll wrap us